Dr. Pankaj Singh, Assistant Professor in Cardiology in UNMICRC Institute of Cardiology in Ahmedabad. Today here we are going to discuss in heart diseases in pregnancy. Coming to the congenital heart disease in pregnancy, first is ASD, which is most common cyanotic congenital heart disease in pregnancy. Even large shunts well tolerated if AVR is less than 3. Would units hemodynamically significant ASD should be closed prior to pregnancy. Maternal risk of thromboembolism is there up to 5%, atrial arrhythmias of 5%, unrepaired ASD and repair after 30 years. Obstructive and fetal risk, unrepaired ASD, preeclampsia, IUGR 3 to 4% of increased risk, repaired ASD no risk, ASD in offspring there is 2.5% risk. Spontaneous vaginal delivery is appropriate, PPH, acute blast not tolerated, careful monitoring while IV cannulation, air embolism, paradoxical pregnancy, air embolism or paradoxical embolism should be avoided. Pregnancy not an indication for prophylactic ASD or P4 closure. Antenatal cardiac follow-up, 2 visits is important. Coming to VSD, small perimembranous restrictivity, WHA come under WHO class 2, other VSDs with left heart dilatation come under class 3 and VSD with PH comes under class 4. Pre-conception counseling should be done accordingly. Hemodynamics, antenatal fall in SVR, PVR does not alter degree of shunt, labor which increase in SVR, increase left to right shunt, acute bloodless and vasodilation in delivery causes shunt reversal, avoid vasodilators, vasoconstrictions, oxytocin like oxytocin is well tolerated. Maternal is small VSDs are well tolerated, corrected VSD good prognosis of if VSD is not corrected and is large, then progression of pulmonary vascular disease in pregnancy is fast. Obstructive and fetal preeclampsia more than in general population, and there is 4 to 11% inherent risk of VSD in offspring. Follow-up visit 2, spontaneous vaginal delivery is appropriate, infective endocardial prophylaxis is recommended if VSD is unrepaired. Coming to AVSD, repaired AVSD class 2, residual AV valve regurgitation come under class 3 and AVSD with PH come under class 4. Maternal risk is there of atrial arrhythmias, paradoxical embolism, worsening of AV valve regurgitation, heart failure. Obstructive and fetal risk, there is preeclampsia risk is there, 6% increased risk of complex congenital heart disease and mortality in offspring. Spontaneous vaginal degree is appropriate, infective endoprophylaxis is recommended, follow up in each trimester. Pulmonary stenosis relatively well tolerated if the right ventricular pressure is less than 70% of systemic pressure, right ventricular fraythia, arrhythmias can occur. Balloon valvuloplasty is considered if peak gradient is more than 64 mm of Hg. Caesarean section is considered when there is severe PS and patient is in NYHA class 3 or 4 despite OMT. Epstein anomaly, hemodynamics depend on TR severity and cyanosis. Epstein anomaly without cyanosis comes under class 2. Maternal risk is of RV dysfunction, heart failure, pre-excitation arrhythmia, paradoxical embolism and shunt revulsion with fall in SVR are there. Usually tolerates pregnancy well, spontaneous vaginal delivery is preferred. CS if RV function deteriorates in pregnancy, infective endocarditis is recommended. Fetal risk of increased prematurity in congenital heart disease is there. Pregnancy in women with Epstein anomaly is well tolerated and it is associated with an increased risk of prematurity, fetal loss and congenital heart disease in the offspring. In addition, a significantly lower birth weight is found in the offspring of cyanotic versus acyanotic women with Epstein anomaly. Paternal Epstein anomaly also seems to result in increased risk of congenital heart disease in the offspring compared with the incidence in the general population. CCTGA, isolated CCTGA comes under WHO class 3, pregnancy well tolerated, predisposed to developing AV block, beta blocker must be used with extreme caution, and irreversible decline in RV function has been described in 10%. Class 4, if NYHA class patient is in NYHA class 3 or 4, EF is less than 40%, severe TR, because there are increase of systemic RV dysfunction, systemic AV valve regurgitation, AV block, atrial arrhythmia. These are the complications that mother faces with CCTGA while going into pregnancy. So CCTGA and pregnancy, the conclusion is successful pregnancy can be achieved by most women with CCTGA. The most common cardiovascular complication is supraventricular arrhythmias, but pregnancy does not seem to impair right ventricular function in the long term. Nevertheless, pre-conception counseling and tertiary care during pregnancy for women with CCTG are recommended. Top hemodynamics fall in SPR, increase in right to left shunt, increase in maternal fetal hypoxia. Hypoxia causes pulmonary vasoconstriction, that increases also second right to left shunt. Blood loss in liver, hypotension worsens right to left shunt. Associated AIV present worsens congestive heart failure. Pre-repair, if top is repaired, then arrhythmias, heart failure, thromboembolism, progressive aortic root dilatation, endocardial risk is there. Post-repair, dysfunction of the right ventricle, moderate to severe pulmonary regurgitation can be there. Outcome better after ICR. After ICR there can be severe PR with RV dysfunction, follow up in every trimester, medical treatment. If refractory, consider for transcutaneous pulmonary valve intervention. Transposition of gate artery post-operative, if operated, comes into WHO risk class 3. Atrial baffle, atrial arrhythmia, severe impairment of RV function can be there. If arterial switch is done, obstruction, regurgitation risk is there. Bradycardia or junctional rhythm can be there, so beta blocker can be used with caution. Any irreversible decline in RV function in 10% of cases are there. Fontan circulation, successful pregnancy possible in selected patient with intensive monitoring comes under class 3. Class 4, patient with oxygen saturation less 85%, depressed ventricular function, moderate to severe AV rejection, protein losing interval come under class 4. So in this class of patient, pregnancy is contraindicated. Coarctation of aorta repaired, there is risk of restenosis, site rupture. Unrepaired, there is a hypertension, risk of aortic rupture, rupture of cerebral aneurysm, PIH, associated bicuspid aortic valve dilatation, aortic dilatation. So close surveillance of BP, avoid aggressive treatment to prevent placental hypoperfusion. Percutaneous intervention associated with high risk of aortic dissection only if severe hypertension persists despite maximal medical therapy and maternal fetal compromise, then use of covered stents may lower the risk of dissection. Etiology of aortic dilatation, which comes if dilatation is more than 45 mm or more than 50 mm in bicuspid aortic valve, pregnancy is contraindicated and comes in conduct WHO class 4. So Marfan syndrome, elidal bicuspid aortic valve, Turner syndrome, tetralogy of Fallot, hypertension, atherosclerosis, all are causes of aortic dilatation. Increase the susceptibility to dissection, hemodynamic changes, hormonal changes which lead to the histological changes in the aorta. Dissection timing is more common during the last trimester of pregnancy and the early postpartum period. The diagnosis of aortic dissection should be considered in all patients with chest pain during pregnancy, as this diagnosis is often missed. Marfan syndrome, bicuspid aortic valve, there is factors for dissection, family history of dissection, rapid growth. Following elective aortic growth is when patient remain at risk of dissection in the residual aorta. 50% of the patients with bicuspid aortic valve and AS have dilatation of the ascending and associated mitral regurgitation. Marfan syndrome surgeries done, pre-pregnancy surgery is recommended when the ascending aorta is more than 45 mm. Bicuspid aortic valve pre-pregnancy surgery should be considered when the ascending aorta is more than 50 mm. If progressive dilatation occurs during pregnancy before the fetus is viable, aortic repair with the fetus in utero should be considered. When the fetus is viable, cesarean will followed by directly by aortic surgery is recommended. Arrhythmias in pregnancy. Mechanism of arrhythmia in pregnancy is mostly hemodynamic factors, that is hypervolemia, stretching the myocytes, early after depolarization, shortened refractoriness, slowed conduction, increase in length of the re-enteral circuit. Hormonal factors like estrogen increases catecholamic responsibility. Higher intrinsic rate and shorter nodal recovery time are the major mechanism for arrhythmia in pregnancy. Anti-arrhythmic amiodarone is mostly contraindicated in pregnancy and can be used in refractory cases as a last resort, while other drugs are more or less can be given in pregnancy, which can control arrhythmic events. So I am not going to very deeply discuss about it. Supraventricular arrhythmia like AV, NRT, vagal maneuver can be first tried, then if not controlled, then adenosine IV can be given, and IV metoprolol or propranolol can also be given. Verapamil can also be given. Maintenance, beta blocker, verapamil, sotalol or flecainide. Catheter ablation in drug refractory cases, prophylactic therapy, metoprolol, sotalol can be given. Accessory path में orthotomic AVRT common, treatment same as AVNRT. If AF with pre-excitation, procainamide or albuterol can be given, and maintenance with beta blockers, flecainide, and quinidine and alternative. Ventricular tachycardia, VT without structural heart disease Idiopathic outflow tract VT is RBOT, VT common, hemodynamic stable, usually good prognosis, metoprolol first line of drug, sotalol ficline second line, lidocaine alternative, amiodarone should be avoided, fascicular ability, verapamil can be used. Long QT syndrome, syncope or sudden death in postpartum period, no increases in antenatal period in studies, precipitated by bradycardia, stress, altered sleep, propanol is the drug of choice, metoprolol is ineffective. So, propanol is the drug of choice in long QT syndrome in pregnant patients. VT with a structural heart disease like cardiomyopathy, acute coronary syndrome, congenital heart disease, lidocaine is the drug of choice, procainamide quinidine is alternative, maintenance with beta blocker sotalol, maxetilin alternative, flecainide is contraindicated, amiodarone last choice reserved drug in VT with structural heart diseases. ICD and pacing is safe in pregnancy. Complete congenital heart valve without structural heart disease does not require pacing in pregnancy. Fetal arrhythmias, coming to fetal arrhythmias, SVT is common, results in hydropetrolis, fecamid, sotamol and digoxin is the drug of choice for fetal arrhythmias. Coming to prosthetic valves, which is also a major concern in the pregnant patients. So, choice of prosthesis is decision in July, mechanical valve need for anticoagulation is there, but bioprosthetic valve used in young patient there is structural wall deterioration. This treatment summary according to Ii-Cce kind, bioprosthetic valve low dose aspirin is only given, mechanical valve risk factor oral anticoagulation and plus aspirin till 36 weeks, mechanical valve without risk factor oral anticoagulation first 5 weeks, then shift to heparin 5 to 12 weeks and oral canticle 12 to 30 weeks, ideal oral anticoagulant till 36 weeks irrespective of risk factors. Mode of delivery, spontaneous vaginal delivery is appropriate. Women on oral anticoagulation goes into labor, immediate cesarean section after reversing with FFP, administer vitamin K and FFP to neonate. Women on LMWA shift to unfractioned heparin. Unfractionated heparin stopped when in active labor. Women on LWH and if emergency CS required, reverse with protamine. Breastfeeding, LMWH, unfractionated heparin, oral anticoagulation all are safe. Coming to heparin versus warfarin, so oral anticoagulants are always better, but there is more fetal wastage. So oral anticoagulation is heparin is considered, which shows less fetal wastage. But if the dose is less than 5 of warfarin and so common less than 2, then continue up to 30 weeks oral anticoagulation, then shift to heparin. So, pregnant patient with mechanical valve, therapeutic anticoagulation with frequent monitoring should be done. Baseline warfarin dose less than 5, then continue warfarin with close INR monitoring, or continue shift to LMWH or unfractionated heparin 6 to 12 weeks, then 12 to 36 weeks give oral anticoagulation, and after that, after 36 weeks, then shift to unfractionated heparin. Prosthetic valve thrombosis in pregnancy, if this occurs, if there is suspicion of mechanical heart valve thrombosis, immediate echo TE should be done, obstructive thrombus visualized. Then critically unwell patients, if surgery is available, go for surgery. If surgery is not available, then go for thrombolysis, but there is risk in pregnancy of to fetus and mother both. If small, less than 10 mm thrombus, recent indicate yes, then intravenous aspirin should be given. If dyspnea resolves, then continue intervention unfractionated. Not resolved, then go for surgery. Coming to pericardium cardiomyopathy, which is a major concern nowadays, incidence has increased of pericardium cardiomyopathy in patients. The region has not unknown, but the pathophysiology is better understood now. Older names are Meadows syndrome, Zaria syndrome, postpartum myocarditis. Incidence is 1 in 100 in Nigeria. African countries are worstly affected by pericardium cardiomyopathy. 1 in 300 in Haiti, 1 in 1000 South Africa, 1 in 2300 USA, 1 in 5000 Sweden, 1 in 20,000 in Japan. Development of heart failure towards the end of pregnancy or within 5 months following delivery. Absence of another endocrine cause of heart failure and left ventricular systolic dysfunction with LVEF of less than 45%, the LV may or may not be dilated. Development of heart failure in PPCM is more commonly after first month of postpartum, more commonly after delivery. Pathogenesis, cardiac angiogenic imbalance, mostly accepted scientifically proven, altered prolactin processing 16 kDa protein by induction of microRNA 146. Others are immune response to fetal cells, genetic predisposition, genetic truncating variants of tatin, viral myocarditis, This is the pathophysiology which shows that prolactin is the main culprit for the PPCM. So reactive oxygen species causes active CD, and pituitary gland secretes 23 kDa prolactin, which comes in contact with active CD or vascular endothelial growth factor secreted by placenta, which converts this prolactin into 16 kDa prolactin, which causes impaired metabolism, impaired microcirculation, endothelial cells are apoptized, capillary dissociation, vasoconstriction, which further leads to PPCM. So angiogenic imbalance and residual myocarditis in recovered pericardium cardiomyopathy is still higher, and there is angiogenic, if even the patient is recovered with PPCM, there is angiogenic imbalance continuum. So if the patient has even recovered, there is risk of occurring PPCM in next pregnancy also. So if there is minor LV dysfunction is also present, then pregnancy is contraindicated in PPCM. Next pregnancy, subsequent pregnancy is contraindicated in PPCM patients. Risk factors in which patients can PPCM can occur as age more than 30 years, going for pregnancy, frequent descent, multiple gestation, maternal cocaine abuse, long-term oral tocolytic therapy with beta-adenine agonists such as terbutaline, selenium deficiency, not a proven risk factors. Clinical presentation, most common complaint is dyspnea. Other frequent symptoms like cough, orthopnea, PND and hemoptysis, non-specific fatigue, chest discomfort or abdominal pain. Systemic and pulmonary embolia are more common in PPCM than other cardiomyopathies. Risk is exacerbated by the hypercoagulous state induced by pregnancy. Differential diagnosis, there is a PPCM comes with pre-existing idiopathic dilated cardiomyopathy unmasked by pregnancy, pre-existing valvular heart disease unmasked by pregnancy, pre-existing familial dilated cardiomyopathy unmasked by pregnancy, pre-existing unrecognized congenital heart disease, pregnancy associated myocardial infarction, HIV or AIDS associated cardiomyopathy and pulmonary embolism. Investigation, diagnosis of exclusion is there. NT-proBNP if elevated more than 100 picogram per ml, poor prognosis. Echo LV may or may not be dilated. Cardiac MRI LG is present, non-specific. Biopsy, no pathognomic finding. PPCM, coming to the PPCM management, immunosuppressive agents like efficacy is unclear. Few studies show role in biopsy proven myocarditis. Empiric immunosuppression is not recommended. Significant side effects are there. No clear evidence of benefit is there. Retrospectives of 6 women treated with IVIG and 11 control treated convexly. After 6 month follow-up, absolute increase in LVF IV in IVIG groups are seen, but empiric immunosuppression is not recommended. If proven myocarditis is there, then immunosuppression can be given. Delivery, timing and mode of delivery is limited data. PPCM with advanced heart failure, prompt delivery for maternal cardiovascular indications. Early delivery is not required if the maternal and fetal conditions are stable. Caesarean is generally reserved for obstructing indication. Vaginal delivery still can be tried. Anticoagulation should be given because there is increased risk of embolism in this patient. Breastfeeding should be avoided because of the potential effects of prolactin subfragments, because as the breastfeeding is done, prolactin secretion will increase, which will further decompensate the PPCM. Bromocriptine inhibits prolactin secretion, so dopamine D2 or receptor antagonist is tried in PPCM patients and given good results. These are the studies showing the bromocriptine 2.5 mg BD 2 weeks, 2.5 mg 6 weeks, 31% better results in bromocriptine arm have shown the study. Bromocriptine treatment was associated with high rate of full LV recovery and low morbidity and mortality in PPCM patients compared with other PPCM cohorts not treated with bromocriptine. No significant difference was observed between women treated, suggesting that 1 week addition of bromocriptine to standard heart failure treatment is already beneficial with a trend for better full recovery in the association. So accordingly, if a patient present with mild, moderate or severe heart failure, that is if there is hemodynamics are stable, then give only 2.5 mg OD drug for 7 days. If hemodynamics is stable but respiratory insufficiency there, NIV should be given to the patient, and bromocriptine should be started with BD dose of 2.5 for 2 weeks, followed by OD dose for 48 days. If severe hemodynamic instability and respiratory insufficiency there, IIBP NIVs will be tried, and bromocriptine should be started with 2.5 mg dose and increase up to 10 to 20 mg per day dose till the prolactin levels come to normal. So So goal directed medical therapy of beta blocker, ACE inhibitor, ARBs, mineralocorticoid receptor antagonist, evaporating should be given after the delivery, and even after the full recovery of the patient, beta blockers should be and all gold GDMT should be continued for 6 months, and after 6 to 12 months, if LV function has recovered and comes to normal, first withdraw the drugs step by step, and more than 80 months, if after more than 80 months there is no residual LV dysfunction, then discontinue the drugs. Not directly, if the LV function recovers normal, not all the drugs should not be stopped. Apparently it should be stopped step by step and followed up to the 2 years and up to the 12 to 18 months. Predictors of LV recovery: LV diastolic dimension is less than 55 to 60 mm, LV if is more than 30 to 35, fractional sorting less more than 20, lack of troponin elevation, a lower level of plasma BNP, absence of LV thrombus, absence of blistering feeding, non-African American ethnicity. Prognosis and relapse: persistent LV dysfunction, higher risk of relapse with subsequent pregnancy, 50% of further deterioration in LV dysfunction, increased morbidity mortality with subsequent pregnancy, premature delivery and abortion more common. Complete recovery, better prognosis with subsequent pregnancies compared to persistent LV dysfunction. 20% may have a relapse, rate of recovery is higher, morbidity mortality is lower, likely to have a normal pregnancy. The period of mortality in PPCM is more common after 5 to 6 months after the delivery. Conditions in which pregnancy risk is WHO class 4, that is pregnancy is contraindicated, is pulmonary arterial hypertension, severe systemic ventricular dysfunction, previous pericardium cardium with any residual impairment of left ventricular function, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aorta dilated more than 45 mm, and bicuspid aortic valve, aortic dilatation is more than 50 mm, and native severe coarctation. Hypertrophic cardiomyopathy, there is increased preload due to hypervolemia, increased LV cavity size, reduced LVT obstruction, increased heart rate, increased cardiac output counteracts these. So LVT gradient increases. In LA, volume overload is there, LV diastolic dysfunction is there, increased risk of AF, reduced diastolic filling due to tachycardia, LVOT obstruction, superadded AF, pulmonary, which can cause pulmonary edema. Treatment is acute hemodynamic collapse, then give IV FLNRP, beta blocker diazepamide, epidural anesthesia causes systemic vasodilation and hypotension and severe LVOTO, so avoid epidural anesthesia in this. Fluids should be given, ICD in second trimester if needed. All other management is the same except for amiodarone. Acute coronary syndrome in pregnancy, ISD most common cardiac cause of maternal death in Western countries, most cases in the third trimester and postpartum period. Infarction commonly involves anterior wall. 4 major risks for old maternal age, hypertension, diabetes mellitus, and obesity. Etiology of acute coronary syndrome in pregnancy is most atherosclerotic thrombus more common than dissection. SCAD is 33%. So, if the patient presents immediately postpartum and present with ACSO's dissection, SCAD should be suspected and treated accordingly. ACS management, tropinins are preferred to CKMB treatment. If patient comes with STEMI, coronary angiogram, we preferred BMS over DES. Thrombolysis, high complication rate because pregnancy is also relative contraindication. If non-ST elevation ACS, without risk criteria, conservative strategy, with risk criteria, invasive strategy should be followed. Antiplatelets, aspirin, FDA class 3 is given at pregnancy after 12 weeks. Stop near to term to avoid premature closure of ductus. Secreting breast milk, better to avoid metabolic acidosis in neonate. Processed placenta affects organogenesis. All clopidogrel antiplatelets are class C drugs. Low dose aspirin recommended after 12 weeks in Naegeli syndrome, prosthetic valve, to prevent preeclampsia in women with history in prior pregnancy. Statins category X, contraindicated because of tetrogenicity, inhibits cholesterol synthesis, down regulates head signaling. Lipid metabolism in pregnancy is dyslipidemia in pregnancy does not require treatment in absence of risk factors. Ezetimibe, favipiravir, nicotinic acid, FDA class C, not recommended. Bile acid binding resins, drug of choice for hypercholesteremia, familial and acquired. LPA levels increased in pregnancy. Antiangiogenic like nitrates category B and C can be given. Maternal hypotension, fetal hypoperfusion in few cases. Nicorandil not studied. Renol is category C. Ivabrine not studied. Contraindicated in pregnancy. Pregnancy associated SCAD, non-traumatic, non-iatrogenic separation of coronary arterial wall, increasing incidence in menstrual wall. Left men may be more commonly involved and commonly seen in elderly pymigavida. So conclusion, pregnancy associated SCAD patients have more acute presentation and high risk feature than women with non-pregnancy SCAD. The highest pregnancy SCAD occurred during the first postpartum month, and pregnancy SCAD patients less often had extracoronary vascular anomalies, hormonal hemodynamic variations, and yet under undefined mechanism might be significant contribution to pregnancy SCAD. So most patients are present in postpartum. Just after delivery, most patients present with pregnancy associated SCAD. So features of pregnancy spontaneous coronary artery dissection, coronary artery hematoma plus minus tear limits coronary blood flow to myocardium. Pregnancy associated SCAD frequently occurs in first month postpartum, majority of these within first week after delivery. Pregnancy SCAD presentation occurs often severe with ST elevation, myocardial infarction, reduced left ventricular function, left main or multivessel SCAD. Compared to non-pregnancy associated SCAD, pregnancy SCAD has higher risk of presentation. Pregnancy associated SCAD patients are older at time of first childbirth and more frequently have history of multiple pregnancies. Pregnancy associated SCAD patients have fever, extracoronary vascular anomalies. So recommended areas of pregnancy associated SCAD research are hemodynamic stressors, hormonal fluctuations, oxytocin release in breastfeeding mothers, older multiparous mothers, relationship to eclampsia, preeclampsia, peripartum cardiomyopathy, fibromuscular dysplasia, and other extracoronary vascular anomalies. Three types of SCAD. Type 1, there is multiple radiolucent lumen. Type 2, long, diffuse and smooth narrowing. Type 3, focal or tubular stenosis. Pregnancy study SCAD, medical therapy alone unless the following criteria persist. If there is ongoing ZP or ischemia on ECG, recurrent ischemic complaints, cardiogenic shock requiring hemodynamic support, sustained VT VF, is if there is if PCI is feasible, then yes, PCI. If no, that is more proximal SCAD, ostial LED SCAD, very diffuse SCAD, then if present, then go for CABG. If no, then medical treatment. Cardiogenic shock is there, consider IIBP, ECMO or LVAD. Sustained VT or VF is there, consider ICD. If left main dissection is present, isolated left main, PCI if feasible, then do PCI. If not, and if left main SCAD involving LAD or circumflex, then go for CABG. If ongoing ischemia on ECG or recurrent ischemic complaints are not there, then hospital observation to 2-4 days and discharge on medical management. Acute SCAD on angiography, yes, then TIMI flow assessment should be done. If TIMI flow is 2 and 3 and clinically stable patient, conservative management should be done. And if TIMI flow is 0 to 1 or clinically stable, re-escolize with inpatient monitoring for 5 to 7 days, consider CABG in high volume surgical centers. If acute SCAD is not visible on angiography, then do OCT IVS, false lumen internal pneumotomy, yes, then again do TIMI flow assessment. APLA syndrome treatment in pregnancy, then APLA positive but no history of prior thrombosis, low dose aspirin throughout pregnancy can be given. With history of prior thrombosis, aspirin plus prophylactic heparin should be given. Thrombotic given in pregnancy, oral anticoagulation should be given second and third trimester only. Catastrophic APLA, that is more than 4 organ system involved, IV agent plasmapheresis should be done. This is a chart showing all the categorized in a single chart. Valve disease, pregnancy not advised in women with severe mitral and aortic stenosis. Mechanical prosthetic valve if elective anticoagulation not possible. Pregnancy management, close follow-up, drug therapy for heart failure or arrhythmias, balloon valvuloplasty or surgical valve replacement in refractory cases. Delivery, vaginal delivery is always preferred. Cesarean section in case of fetal and maternal instability. Early delivery for clinical and hemodynamic deterioration, consider hemodynamic monitoring during labor and delivery. Complex congenital heart disease, pregnancy not advised in women with significant ventricular dysfunction, severe atrioventricular valve dysfunction, failing Fontan circulation, and O2 saturation less than 85. Pregnancy management, close follow-up should be done. Delivery, vaginal delivery preferred. Cesarean section in case of fetal or maternal instability, consider hemodynamic monitoring during labor and delivery. Pulmonary hypertension, pregnancy not advised for all women with established pulmonary hypertension. Pregnancy management, close follow-up. Yearly institution of pulmonary vasodilatation, delivery, vaginal delivery is preferred. Cesarean section in case of fetal and maternal mobility. Timing of delivery depends on clinical condition and right ventricular function. Early delivery is advisable. Diuresis after delivery to prevent RV volume overload, and extended hospital stay after delivery. But CS is more preferred in pulmonary hypertension patient to avoid maternal and fetal complications. Aortopathy, pregnancy not advised in some women with Marfan syndrome, bicuspid aortic valve with aortic dilatation more than 45 mm, more than 50 mm in bicuspid aortic valve, Turner syndrome, rapid growth of aortic diameter, or family history of premature aortic dissection. Pregnancy management: treat hypertension, beta blocker to reduce heart rate, frequent echo assessment, surgery during pregnancy or after cesarean section if large increase in aortic dimension. Delivery: cesarean section in case of significant aortic dilatation like Marfan syndrome more than 40 mm, bicuspid aortic valve more than 45 mm, Turner syndrome. In Turner syndrome, in dilated cardiomyopathy, pregnancy not advised in women with left ventricular ejection fraction less than 40, history of pericardial cardiomyopathy. Pregnancy management: close follow up, beta blocker, diuretic agent for volume overload, vasodilator for hemodynamic and symptomatic improvement. Delivery: vaginal delivery is preferred. Cesarean section in case of fetal and maternal instability. Consider hemodynamic monitoring during labor and delivery. Early delivery for clinical and hemodynamic deterioration. Take home message is cardiac pathology requiring vigilant monitoring should be close follow-up, and early institutional delivery should be done in cases of severe stenotic lesions, outflow tract obstruction, prosthetic valves, pulmonary hypertension, cyanotic congenital heart disease, Marfan syndrome, aortopathy, impaired LV function, and pericardiomyopathy. If not recovered fully, avoid subsequent pregnancy. Coming to arrhythmias, avoid amiodarone for arrhythmias in pregnancy. Anticoagulation studies: if dose is less than 5 of warfarin and less than less than 2, then continue oral anticoagulants for 36 weeks and then shift to unfractionated heparin. If dose is more than 6 to 12 weeks, shift to unfractionated heparin or LMWS, then 12 to 36 weeks give oral anticoagulation, and after 36 weeks and then again shift to unfractionated heparin. Avoid NOACs in pregnancy, and whenever pregnant patient just immediately postpartum present with acute coronary system, always suspect coronary dissection, SCAD in those patients and treat accordingly. Thank you.